Bir sonraki konuşmacımız Madrid'den Jose Medina, nörojenik mesanelerde idrar yolu enfeksiyonu yönetimini bize anlatacak.
Morning, everybody. Thank you for the invitation, for the presentation. And now I go to follow the previous topic about the infection in patients with the neurogenic bladder. First, I want to include this study that to me is very important, that reflects in a general way the risk factor for infection that our patient had. As you can see, the patient with neurogenic bladder had a problem to void, so there is a residual in the urine, and this is an incomplete voiding is a risk factor for infection. Most of the patients had a catheter, indwelling intermittent catheter, and is another risk factor of infection. And in many cases, they had a high pressure in the ureter that is also a risk factor for infection. In the European Association, we propose use this method to classify the risk factor for infection in our patient, and we had to select the correct antibiotics. If we move on to the treatment of the UTI in patients with neurogenic bladder, I select two articles to revision. This one state that is very important, the correct diagnosis of the infection, but as previously was mentioned in the previous presentation, there are not an accepted criteria for the diagnosis. And about the prevention, yesterday I talked about the recurrent urinary tract infection. There are few evidence, but in patients with a neurogenic bladder, the evidence is lower. I also include this figure that the previous presenter included, that so all the risk factors that the patient with neurogenic bladder had. They had, in some cases, catheterization. They had risk factor for the bacteria go into the bladder. Some of them are immunodeficiency. For example, a diabetes patient, someone had bladder ischemia, and there are, in some cases, related to the infection or related to the disease, defect in the urothelial layer, and all is a big bug to have an infection. If we had to move to the diagnosis, the patient came to our clinic, and the first thing that we had to do is urine analysis. If the patient is asymptomatic and the urine analysis is negative, we don't need to do for further testing. But if the urine analysis is positive, we had to move on to the urine culture. In the patient that has symptoms and the urine culture is negative, we had to think about asymptomatic bacteriuria that, as previously mentioned, is not require treatment. But if the patient had symptoms, we had to distinguish between fever and not fever. If the patient had no fever, we had to treat with antibiotics during 1 week. Short treatment is not correct in this patient. If the patient has fever, we require more than a week on antibiotics. This study is quite similar. The algorithm is quite similar. Can you see? We don't need to treat the asymptomatic bacteriuria. And when the patient had an infection, we had to distinguish those with no fever and those with fever. But if we think about how to prevent the infection in patients with the neurogenic bladder, that is the main thing of my topic, there are some studies, some recommendations. For example, in this study, they review all the recommendations to prevent the infection, but in reality, the evidence grades in this study is to general patients. It's not focused on patients that are neurogenic. But I take some conclusion of this article. First of all, we need to evaluate correctly the patient. We need the urodynamics about how the bladder works. It's important that especially the patient with high pressure in the bladder are those patients that had the greatest risk of infection. More, we have to select, when a catheter is required, the best catheter, hydrophilic, closed system is an indwelling catheter is necessary. Sometimes we need to think about antibiotic-coated catheter as well as broader irrigation. Well, other methods to prevent the infection. I take this article that consists of different antibiotic strategies to prevent the infection. They change the antibiotics weekly. They started with amoxicillin, then move on to cefixime, fosfomycin, nitrofurantoin, and different antibiotics. And they demonstrate that changing the antibiotics every week in patients with many infections, there is a reduction of the number of infections. You can see before the antibiotic treatment, 9 infections to 1.5 per year. There is a reduction also in the number of febrile infections, 5 to less than 0.5, and also a reduction in the hospitalization. And moreover, with antibiotics, it was given weekly, there is a few number of multi-drug resistant microorganisms, but we need to have other strategies. Here is a summary of the regimen and the what about the evolution of the patient. If we're thinking about not antibiotic treatment, we can think about cranberry, dimanose, or probiotics. The studies about cranberry in patients with neurogenic bladder are scarce. As you can see, the evidence is few and there are no statistical differences. For example, next year is going to be published the recommendation, the guideline by the nurse in the EIU about how to prevent the infections in patients with a catheter, and the recommendation is no give cranberry at other products because there are no evidence to prevent the infection. And what's next? Yesterday, I speak about the immunoprophylaxis or the vaccination, and what is the evidence about the immunoprophylaxis in this patient. This is the first article. It was published about 30 years ago. There is few patients, 10 patients, all with a neurogenic bladder due to a spinal cord injury, and they demonstrate that the infection can reduce. There are other studies, a clinical study that is going to be done, but about the publication, I saw this one by weight that include 25 patients in the Üroloji arm and 23 with placebo. And most of them had a indwelling catheter or intermittent catheterization, and the mean number of infections in many cases was more than 5. This is the results. As you can see, the main number of infections in both groups was 2.2 in the active group with Urivaxone and 2.8 in the group with placebo. All the different were not statistically significant. And also there is the time from the start of treatment to the first infection is what 58 days in the group with Urivaxone and 30 days in the group with placebo. It's different, but not statistically different. If we want to find different statistically, this is the study. It's not published, but it was presented some years ago in the ICS, and now they had more patients by my friend Salvador Arlandis from La Fe of Valencia. They get Euromoon, that is the vaccination to the patient, and they saw that the percentage of infection of neurogenic bladder before the treatment was 4 and go to 0 in those patients with the vaccination, and they had a longer time without infection. 2 months to 4 months. It's important to tell the patient that the immunoprophylaxis in this patient is not going to go to no infection, but is effective in many cases to reduce the infection. And they also get a satisfaction survey to the patient, and most of the patient was satisfied with the treatment. And finally, this is a good result with patients with a catheter, intermittent catheterization, and we had to say that the patient had about 1 to 2 infections per year. Usually the patient has now to control, and the most important thing that we had to explain the patient how to manage the catheter, and these patients are really expert in catheterization, and usually they don't have infections. So to conclude, asymptomatic bacteriuria does not to be treated. In patients with a catheter, we had to optimize the treatment, and we had to start with not antibiotic measures, and immunomodulation, immunoprophylaxis can be a good option for our patient. Thank you very much.
Sayın Polo'nun güzel sunumu için teşekkür ederiz. Salonda sorusu ve katkısı olan var mı?
Çok teşekkürler Doktor Medina'ya bu güzel sunumu için. 2 tane sorum olacak. Bir tanesi VOCA dediniz, haftalık siklik antibiyotik profilaksisi. Rutin kullanımı için özellikle hangi hastalara bunu tercih etmeliyiz? İkincisi de antibiyotik direncine karşı bakteriyofaj kullanımı ile ilgili düşünceleriniz nelerdir?
Okay. Well, first, as previously I mentioned, I usually start with not antibiotic treatment, and when no antibiotic treatment, I go to the antibiotic. But usually, I start explain the risk factor for infection, and now we are using the immunoprophylaxis in many patients. For example, in Spain, there are 5 hospitals that we are doing a research to demonstrate the efficacy, and it's good. And we had to inform the patient that the normal is a reduction in the infection in 1/3, but it's probably that the patient had infection. And when the immunoprophylaxis fail, we move on to the prophylaxis with antibiotic. And regarding bacteriophages, it's not approved in Spain. So I'm sorry, but I don't have experience. But I chat with my colleagues, especially from the east of Europe, that they had experience in bacteriophages. And it can be a good treatment, but it's difficult to implant because usually had to offered to patients with many infections, probably more than 1 per month. But I don't have experience, sorry.
Doktor Medina, dün de aynı soruyu sordum. Bu nörojenik mesane hastaları için semptomatik ateşli enfeksiyonu olan hastalarda özellikle intrakaviter gentamisin, bu Padova ve Venedik grubunun çalışmasından sonra 2022'de Ekim ayında yayınlandı biliyorsunuz. Ben çok memnunum bu tedaviden. Sizin bu konudaki fikrinizi almak istiyorum.
Well, in a patient with fever, I usually use antibiotic in intravenous, and I don't have experience with intracavitary antibiotic in an acute phase. I usually use at prevention, but I don't have experience in acute phase, and I'm not pretty sure what is the effect that the antibiotics go into the blood, but it can be an alternative, but I don't have the experience, sorry.
Yine aslında çok benzer bir soru olacak, bahsedildi ama bir hasta grubumuz var bizim. Multiple sistem atrofili veya çok ileri derecede komorbiditesi olan üretral forey kateterli, yatağa bağımlı bir hasta grubu. Bunlarda bazen suprapubik katetere bile geçemiyoruz çünkü çok kuvvetli antikoagülan tedavi alıyorlar. Bu antikoagülan tedaviyi kesmemize izin vermedikleri için suprapubik bölgeye taşıyamıyoruz. Ve bu hastaların da biliyoruz ki ve maalesef yaşıyoruz ki özellikle ateşli idrar yolu enfeksiyonları mortalitelerinde ve morbiditelerinde çok önemli rol oynuyor. Bize pratikte böyle bir reçete verebilir mi? Nasıl bir yol izleyelim bunların sonda bakımında?
Well, very practically, we had to instruct very well the patient how to take care of the patient. We usually, when a patient had a problem, They had the telephone direct to our clinic, and they also phoned to our nurse if they had any problem. And in this patient, when we use the neuromodulation, we use during 6 months, and we try to use the better catheter with the patient. Sometimes we tried to different catheter to the best adapt. And now in our hospital, we are doing a research with a new catheter that is a closed system, but without a back. So it can be an option. You can open and close, but it's without a back. It's a new system that it was developed in Spain. And we are doing a research and can be a solution.
Oktay hocamıza da son olarak söz verelim.
Teşekkürler. Konuşma için de teşekkür ediyorum. Ben şeyi sormak istedim. Bu tip hastalarda intrakaviter uygulamalar hyaluronik asit bazlı ya da kondroitin sülfat bazlı intrakaviter uygulamaların yeri var mı? Sizin pratiğinizde uygulamanız var mı?
Well, really, I think that it's a good question. It can be a place and not used, but I think that we need more study to determine what is the best practice. It can be important, and also it's important to analyze the microbiome of this patient and try to protect from the infection.
Çok teşekkür ediyorum Doktor Medina. Çok yararlı, bilgilendirici bir toplantının daha sonuna geldik. Hepinize çok teşekkürler. Toplantılar devam ediyor. Bir sonraki seansta görüşmek dileğiyle.